And then there's the T1 high grades. So, diagnostic resection, staging resection, induction BCG, 3-month cysto, papillary tumor, you resect it, it's T1 high grade. What does that conversation look like?
If this is a situation where, I'm truly worried about these patients' concerns, I mean, I think there's a lot of factors that go into it, both the tumor characteristics, multifocal, extent of lamina appropriate involvement. Is it multifocal? Is it extensive or is it minimal invasion? Is there associated CIS? All those tumor factors go into it, but also patient factors are very important. Is this, a young and healthy male, or is this a very comorbid individual that maybe not the best cystectomy candidate? So I think a lot of that goes into those discussions, whether I'm particularly worried about this patient and counseling more towards an early cystectomy, or is this a patient that probably would be better served with an additional attempt with bladder preservation, even if they're at a higher risk for progression.
Right. So, of course, it's not cookbook, and there's patient desires, patient comorbidities, disease characteristics. So let's start out with maybe like the one end of the spectrum: nodular, multifocal, LVI, extensive, and they're willing to receive a cystectomy. To me, that's kind of a no-brainer next step.
Yeah, I would agree. And LVI is so uncommon in high grade T1. That's a patient that I'd be really worried about, and potentially even counseling that, they may have nodal involvement and may need systemic therapy. Typically, at least in my experience, that would be after cystectomy, verifying the pathology stage, verifying the nodes. But I know that there are some centers that sort of advocate potentially for systemic therapy, even for these very high risk T1 patients. I don't know if that's necessarily indicated or beneficial, and I think the data is kind of weak overall on that. But whenever you see a variant histology, LVI, these very high risk features, I think definitely counseling those patients towards cystectomy. And I worry we have very few effective bladder preserving options after BCG has failed. And I think it's such a major unmet need, and cystectomy is curative in the majority of these patients.
The one other thing I'll add is, and maybe you'll get to this later, but the variant histology for these T1 high grades also puts you into that high risk category there, especially if the invasive component our pathologist here will read it as the invasive component contains sarcomatoid or any of those other sorts of features. I mean, this is definitely concerning, certainly pushing me towards cystectomy for that patient.